D by Dr. Lino. So can I just request you if you can wrap it up within 10 minutes, because then we can have some discussion and finish all the presentations on that.
So good morning, everyone. Today I'm presenting on behalf of Medicine One, the vintage ST. To begin with, we'll start with the spotter. Any guesses for the diagnosis?
Slide goes on.
Any guesses? We'll proceed with the case. And this is a plant aspect of the hand. It's showing some muscle weakness and the wasting of the thinner and hypothinner muscles. And we start with a case of 40 years old male businessman from Jharkhand presented with numbness over both the feet and palm for 2 years, difficulty in buttoning and unbuttoning shirts for 2 years, and skin lesions over the body for last 2 months. He was apparently well before 2 years, then developed numbness and decreased appreciation of sensation of both lower limb and insidious onset, slowly progressive, was present in soles of both the feet to begin with and gradually ascends up to knee and then developed numbness over both the palm. There is history of chapels from the foot. However, there is no history of buckling of knees or no difficulty in getting up from squatting position. There is difficulty in buttoning and unbuttoning of shirt. However, there is no difficulty in overhead activities. He also developed skin lesions over the body for 2 months. There is no pain or itching. He also complains some degree sensation over the lesions. Past history wise, he is a known diabetes for last 2 years only on diet restriction. Examination at the time of presentation, vitals were normal with a BP of 110/70, pulse rate of 90 per minute, and all peripheral pulses were palpable. His respiratory rate was 20 per minute. There is no parallel clubbing, cyanosis, or lymphadenopathy or edema. There was a large angular erythematous plaque lesion of variable sizes with absent sensation to temperature and reduced sensation to touch noted, predominantly over the right arm, left chest, and lower back. There was also satellite lesions as noted in the slide. There is evidence satellite lesion near to the big lesion, and there was a left ulnar nerve thickening noted with multiple healed ulcers and scars noted over the fingers with the resorption of fingertips on few fingers. There was also a left foot dorsum showing a healing tropic ulcer. Some other system examination where respiratory system examination was normal and CVS examination also normal, abdomen examination also normal. Central nervous system examination showed wasting of thinner and hypothinner muscles and tone was normal. Power was gross normal in all 4 limbs. Sensor system showed decreased pain, temperature, vibration, and joint position sensation below the shin and below mid forearm. The reflexes, superficial abdominal reflexes were present in all 4 quadrants. Deep tendon reflexes were diminished. Biceps was absent, triceps was 1+, and supinator, knee and ankle reflexes were absent. These plantars were flexes with there is no cerebral sign. Cerebral signs were negative and meningeal signs was absent. Spinal skull was normal. So summarizing the syndrome complex of this is a 50 years old gentleman with diabetes mellitus in past and now with erythematous skin lesions with the definite loss of sensation or the skin lesions with the satellite lesions, and there is a sensory loss in glove and stocking distribution with asymmetric nerve thickening. So clinical diagnosis considered was a probable Hansen's disease.
It's definite Hansen's.
So his baseline investigation showed a HB of 15.5 with the MCV of 86.2. His HB1C of 6.2 with the TSH of 0.66. His blood-borne virus screening was negative. His split skin smear was done, it was negative, and skin biopsy was done. We'll go through the skin biopsy report at last. Before going on to the skin biopsy report, I'm just going on to discuss regarding Hansen disease and what I learned from this disease, this particular case.
Can I ask one question? Why did you send TSH?
Peripheral neuropathy. Hansen disease, it's a chronic infectious disease caused by Mycobacterium leprae. The clinical manifestations are largely confined to skin, peripheral nervous system, eyes, and upper respiratory tract. The differing immune response to Mycobacterium leprae results in spectrum of disease that has ranged from tuberculosis to lepromatous leprosy. So, only thing I am going to highlight is based on the skin manifestation and based on the pattern of neuropathy, how to differentiate this tuberculosis to lepromatous leprosy. So, based on the readily Joplin classification, there is tuberculosis leprosy, borderline tuberculosis leprosy, and borderline leprosy, and borderline lepromatous and lepromatous leprosy. So, in tuberculosis leprosy, what we see usually is skin manifestation of well-defined hyperpigmented macule or as a raised erythematous brown or copper-colored plaque with well-defined edges. These lesions may be found on any part of the skin as characterized by complete loss of fine touch, temperature, sensation over their surface. They may be usually single or up to 3 in number and can be of any size, and usually asymmetrical lesions. And when it comes to nervous system, it affects a larger corresponding cutaneous nerves are thickened in limited number of cases, and also there will be autonomic nerve damage causing surface dryness and loss of sweating over the lesion. When it comes to borderline tuberculosis leprosy, there will be macular or plaque type lesions numbering 3 to 9 or more, asymmetrically located in any part of the body. There will be classical smaller satellite lesion around the larger one, and the margins of the lesions will be poorly defined. When it comes to nervous system, the patient will have several peripheral nerves are likely to be enlarged as in asymmetrical pattern with the sensory motor deficits. And the next type is the lepromatous leprosy. In this, we usually see diffusely infiltrated erythematous copper-colored or skin-colored lesion, and there will be no loss of sensation over the lesions. The lesions will be innumerable and usually symmetrically distributed. When it comes to nervous system, there will be bilateral. It will be bilateral and symmetrical with sensory loss in a Gloven-Stocking distribution. And the next type is borderline lepromatous. In this, the skin manifestation is usually numerous and bilateral, round or oval, macular, diffusely infiltrated, erythematous or hyperpigmented lesions, and these also will be symmetrical. And in this, there will be some amount of loss of sensation, particularly over older lesion, and however, no loss of sensation noted in the new over fresh lesions. And when it comes to nervous system, there is the asymmetrical thickening of peripheral nerves with or without tenderness, raised to again sensory motor deficits. So last type is this borderline leprosy. In this, there is multiple plaque lesions and not infrequently macular lesion, bilateral, and usually occurs in more or less symmetrical distribution. In annualized lesion, the inner edge will be well demarcated and punched out. Outer edges is ill-defined and merged with normal-looking skin. There is minimal loss of sensation over the lesions. So our patient had a lesion with a satellite lesion and asymmetrical nerve thickening, and his skin biopsy showed a borderline tuberculosis Hansen's disease. Currently, he is following under dermatology for the management.
I don't have any specific questions to ask. If there are any questions from them?
Duration symptoms was 2 years.
2 years.
So what kind of treatment was there?
So intermittent steroids for dermatological consultation. He was not diagnosed prior to this, sir. No tissue presence. Yes, sir.
Not coming here, no?
No, sir. From Jharkhand.
I think there is sometimes I feel that it's almost kind of thought that leprosy is non-existent, and now we are seeing a lot of cases coming up. Something to think about. Thank you so much for discussing it.